Well, thanks very much. As you can see, I'm an old geezer, and I've worked with many state commissioners and state offices over the years, and I wouldn't trade jobs with any of you, but I admire you very much for what you do. Like many of you, I grew up with and have been surrounded with mental illness and parents, siblings, kids for my life. And so this has been my life, really. And now that I'm near the end of my career, I look back on 50 years of being on the front lines as a clinician and as a mental health researcher. It's been a long time, but it's been a lovely career, really. I wish we had done a better job and the mental health system was in a better place, but I'm counting on all you smart young folks to do better than I've done and keep improving things. But I want to talk about two themes here that I think I've learned over the 50 years. The first is that social determinants of health are much more powerful than treatment. And I think Kevin explained some of that. But it's a truism across the world and across all areas of healthcare. If you look at people with any chronic condition, social determinants explain much, much more of the variance in the outcomes compared to anything that we do treatment-wise. The second theme I want to emphasize is that employment is probably the most effective mental health treatment we have. And that was a shock to me when I first realized that. I had spent many years studying medications and psychotherapies and team-based care and so on. And the mental health director in New Hampshire, Don Shumway, brilliant guy, pushed me into studying employment. He said, Bob, look, every year we do a survey and the clients in our system say employment is the most important thing to them and we're not helping them. Could you please figure out what would help them? So we set up a series of experiments. I knew nothing about employment. My background is as a child psychologist and a doctor, and I thought employment was, something off in the periphery that I was not responsible for. But I was interested in studying this. And, we pretty rapidly, through a series of experiments, figured out what worked and what didn't work. That's what you do as a researcher, hopefully. But the thing that really shocked me was there were all these people in our studies who got good jobs, and they got well. I mean, they really got well. They had a regular life. They started to be able to afford their own housing, to afford, to spend time with their friends. They really looked well. And I had never seen people in our ACT programs or in our medication studies who got well like that. I mean, medications are probably important, but people who have an income and who have a meaningful life change in ways that totally shocked me the first time I saw it. Now I've seen it in thousands of people, so I believe it. Let's see. So, people with mental illness want to work. And if you read recovery stories, and I've read a few hundred, maybe a few thousand of them, they almost inevitably talk about work as being part of their recovery. Work helps people get out of poverty. It helps them contribute, control their mental illness, helps them feel like a citizen in the world. And if we start early enough focusing on supported education and supported employment, I think we could prevent a lot of people from falling into the disability system. Could you do the next slide, please? And people with mental illness, there's this huge amount of research on the effects of employment and the effects of unemployment and how they affect disability. But people with even the most severe mental illnesses benefit in the same way as the general population. You know, when they're working, and this is, you know, what I was surprised by. I shouldn't have been surprised because it's been true for all my family members, you know, but they feel better about themselves. They have an income. They start to take responsibility for controlling their symptoms and their illness. They develop friendships. They use less substances, et cetera, et cetera. It's just kind of a natural process when they get to that point. And importantly, I guess, for this discussion of crisis care is the data are very strong that when people go to work, and this is from randomized controlled trials, they are much less likely to go to emergency rooms. They're much less likely to go to hospitals. And if you follow them long enough, they don't even want to hang around mental health centers. You know, 10, 20 years out, people really are taking care of themselves completely. Can I have next slide? Okay, so individual placement and support is just what we call the model of evidence-based supported employment that's developed over the last 30 years. And the important thing about supported employment is that it's a place-trained model. So we eschew completely all the pre-employment training and skills training and practice jobs and sheltered workshops and all that stuff, which I've come to understand really socializes people into disability more than it helps them with recovery. We try to place people as fast as possible in a job that they want, that fits with who they are and what they're interested in. And the IPS model works, and it's expanding all over the world because it's simple, it's direct, it's inexpensive, and it's incredibly effective. And I'll just give you one example to illustrate how it works. You know, we had a young man come into our team. This, you know, this is an early psychosis program, and he hadn't finished high school, became psychotic, got hospitalized. He came to our team right out of, you know, a week in the hospital, was still psychotic and paranoid. And, you know, in the old days, we would have put him in day treatment and so on for a long time. But instead, our smart employment specialist said, oh yeah, I think this guy can work, you know. The rest of us were kind of shocked at that, but she said, you know, look, I spent a couple days with this guy, and I'll tell you what, he's fabulous with animals. You know, he takes care of his dog and knows all about animals. Let's find him a job working with animals, and I think he'll like that and he'll do well. And so, you know, we went around as a team, and, you know, one guy says, well, I'll talk to the pet store where I go, and another says, I'll talk to the farmer where I rent a house, and another says, I'll talk to my veterinarian, and so on. And within a couple weeks, we got this guy a job. He chose the job working in the vet clinic, and he would go in on the weekends, and the employment specialist went with him for the first couple days just to make sure. And he, you know, knew how to wash the animals and feed the animals and walk the animals, and pretty soon he knew how to change their dressing and so on. And he loved this job, and they loved him at the veterinary clinic. And so after a few weeks, you know, he was settling in and just feeling good about himself. They invited him to work during the work days. So he was then working during the week and started to make friends with the other young people that worked in the clinic, you know, so he had a peer support group. And, you know, he's been there for a few years now, and they keep giving him raises and more responsibility and so on. And that's basically how the model works. You know, you figure out quickly who the person is and what they like to do and what they're good at. Next slide, please. So over time, we developed empirically based principles of supported employment. And these are the 8 principles, you know. First of all, anybody is eligible who raises their hand. We don't screen people out because they use drugs or they're not well educated or they're homeless or anything like that. We focus on competitive employment because that's what people want. We help them rapidly to search for a job because people don't want all of the pre-employment baloney that we used to do. We develop jobs in a targeted way. So, you know, the old model was, okay, well, let's develop 5 jobs collecting baskets at the grocery store, and then we'll cram 5 people into those jobs. This model is totally based on each individual and what they want to do as a career. So if a guy wants to work in, I don't know, work in radio broadcasting, you know, we go talk to the radio stations. We don't go to the grocery store with him. So the client preferences completely determine what kind of job the person wants, how much they want to work, you know, what kind of supports they want once they're on the job, and so on. So the long-term supports are completely individualized. Sometimes we are involved with the employer and we call them every week, but if the client doesn't want us to, we just meet with the client outside of work. And one really important principle is that the employment services need to be integrated with the mental health services. So we work as a team to make sure everybody's on the same page. So we don't have the old problem with, you know, the psychiatrist is saying, oh no, you can't work. You need to be stable for a year before you work. And, you know, everybody's got the same message that, you know, yeah, you can work whenever you're ready to work. We're ready to help you find a job. And like almost everything else I was taught at the beginning by the experts, the idea that you should separate vocational and mental health turned out to be completely wrong, you know, as most clinical wisdom is. You know, it turns out every study that compares integrated services with separate services shows that integration is important. And finally, we learned that it's really critical to make sure that everybody gets individualized benefits counseling so they know exactly what will happen when they go to work to their other you know, benefits. Next slide, please. So these are slides from a couple of the many studies that have been done on IPS, one by Gary Bond and one by Kim Muser. And what you can see, those top lines refer to the people in IPS, and you can see that IPS is always vastly superior, as it is in every study, to whatever are the comparator conditions. And in almost all of our studies, we've tried to compare IPS to whatever's the popular model in the local area or in the local country when we do the study. IPS always turns out to be better. If we have next slide. So it's not just getting a job that's better, as those slides show, but people who get jobs in IPS work longer, make more wages, are more satisfied with their jobs, et cetera, et cetera. And in the US, we know that you know, about 2/3 of the people across all these studies are successful. They get jobs, they like their jobs, they stay in their jobs. And the studies always show that it's 2 or 3 times as effective as other strategies. And as I told you before, all these other outcomes go along with employment. You know, once somebody gets employed, they do start to improve in all these psychosocial areas, as well as in medical areas, like, you know, taking care of their own illness. You know, people who have a life and want to go to work take their medicines and figure out how to control their, you know, conditions. And they go to their doctor, as, you know, I've experienced many times, and say, gee, I don't want all these damn side effects. Can we reduce the dose? and most of these folks do real well on half of the dose that they were on. We go to the next slide. So I'm going to now just briefly say this is what we know, and then I'll tell you what we don't know. The efficacy of IPS is well established. We've done randomized controlled trials in more than 20 states and in many other countries. And one of the most interesting things about this to me as a researcher is when the IPS supports stop, and we typically only follow people for a year or two, depending on what they want. But when the supports stop, people do better over time rather than worse. Everything else we do in mental health, think about it, the data show that when the intervention stops, the outcomes erode. But that's not true with employment. It's obviously self-reinforcing. People who are working work more and get more into recovery the longer they're working. The next slide. The next thing we know is that you have to follow the model. So we have fidelity scales, and the programs that have high fidelity always get better outcomes. And we've tried, and other people have tried, altering the model many times in many studies, and the outcomes almost always get worse. So if programs want to try something, we're happy to study it, but there are very few studies. Mostly it's just been refining the basic principles that help people to improve. The outcomes are really unrelated to age, sex, race, ethnicity, symptom level, co-occurring substance use, almost anything you can think of as a poor prognostic factor doesn't affect employment outcomes. So, it makes sense that we try to work with everybody. Now, people that have a long work history are going to do better. When we treat a doctor who's got addiction and is now in recovery, they're going to have a higher income than a guy who's been a truck driver. But that's the only firm predictor. If you could go to the next slide. So here's an important point for you folks who are state directors. We've now done 2 national surveys, and of course the surveys show that IPS is expanding rapidly everywhere. We had 3 programs in 2001. Now we have over 1,000 in the US and over 1,000 in other countries. And in part, this has been sustained because the learning community works so well. This is a program across many of the states where people at the state level and at the program level communicate with each other on a regular basis. So folks like Mark Liverman share what they're learning about providing IPS services in Tennessee. And it's really, really important that, all of us like to learn from our peers rather than, nobody wants to learn from researchers. I've learned that. But if you can connect state directors with other state directors and employment supervisors with other employment supervisors and so on, that's much more effective. And we think that the outcomes in the learning community states are just much better than the non-learning community states. The programs persist, they almost never go out of business, and the programs in those states have expanded and expanded over the years. We think that's because the learning community states provide better training, more technical assistance, more fidelity reviews, and as part of the learning community, they share their quarterly outcomes. So we have quarterly outcomes across these 26 states for years and years now. And the state leaders can, the programs enter their data, they get crunched automatically, they go back to the state leader, and the state leader can look at the quarterly outcomes and they can see the trend over time. So we know exactly how the Great Depression or the COVID pandemic or whatever has affected employment. But more important, the state leader can see, okay, these programs are doing great and these programs need some extra technical assistance. So that's where we're going to put our limited resources. All right, next one. I think I have a couple more slides. Oh, this just shows that in the learning community states, all of these things seem to work much better. If we could go to the next slide. Now, recently, one of the trends has been, since IPS is the only employment intervention for people with disabilities that actually has an evidence base, we have over 30 randomized controlled trials. No other interventions got one, so it's not a big choice. And people have been extending IPS to all these other populations, and there are 2 studies now for people who have anxiety and depression. There are about 4 now for people with substance use disorders. There are 2 big ones for people with PTSD and so on. So we need to learn a lot more. As a researcher, I really believe strongly we shouldn't be putting in place and implementing things that we haven't studied carefully and we don't really know if they work. Next slide. Okay, so I'm going to stop here. I tried to explain, what IPS is, what the employment outcomes are like, what some of the other outcomes are like, and what's going on right now. We at the IPS, I'm retiring, but the IPS Center would be glad to help any of you who are in states that have not yet joined the learning community so that you can figure out how to get lots of free services from the IPS Center and the learning community. And I just leave you with this mantra, work is the best treatment we have. The best treatment we have. Thank you all very much.
Bob, a quick question.
Oh, yeah.
Is insight into the mental illness necessary for the success of the IPS model?
Yeah.
Go ahead.
I don't think it works very well for any of us. I've been depressed for years, and I've had multiple psychoanalyses, and so it hasn't helped a bit, but I keep working.
Thank you. It's a tough act to follow. I appreciate being here. And I was introduced as somebody who's an expert in financing. What I'm really an expert in is struggling with financing. And the next slide, please, if you want to go back. What happened to the slides? They went away. They're in that same, yeah, there we go. Anyway, so I've been struggling with this in my work over many long years also. I'm a geezerette, I guess, if not a geezer. Working in state government in Missouri and in Minnesota, I was privileged to work in both of those places. In the last 5 or 6 years or so, I've been working with many other states who are grappling with this notion. So now you've heard all about the components of IPS, and I think, as Bob described, it is put together in a coherent package. You deliver the services in a coherent way, an integrated way. Sadly, the financing is not so integrated or coherent. So I'm going to speak briefly about some of the different ways states are doing this and trying to do it. The following slides, I will give you sort of the primary sources, but we have to talk a little bit about the process too. So if we could have the next slide. Again, the Frankenstein funding approach is what I'm going to talk about. Next slide. I think we've heard the terms braiding and sequencing quite a bit with respect to employment services. I imagine many of you are familiar with that. We're not allowed to say the word blending usually for any services that we do. As we know, if we're going to use Medicaid, we have to have discrete things. But braiding and sequencing are not always the same, and this confuses people. Typically, braiding is doing two different things simultaneously. So you might have the vocational rehab people paying a milestone payment for an outcome at the same time as your Medicaid system is providing an illness management medically necessary service. That begins to help you think about the complexities here. Sequencing is usually, and we have this in a number of states, some of your states could talk about having one entity pays for one milestone, the next, and trading off on how things are funded. Next slide. There is a tool that you will be able to look at if you're interested. This is just the first page of it. In your materials, there's a link to this tool, which we've used with many states. It looks pretty simple. It's just a grid. And across the top, we have all the different possible funding sources. And across the left side are all the different components that make up all these integrated parts of IPS. You look at that and you think, well, this ought to be pretty easy. We'll get everybody together in our state and we'll go through these and figure out who can pay for what. Next slide. I want to tell you that this is where you can get the thing, that you're going to find out, and an example of that state is Colorado, where in working in Colorado, we discovered, and we've done this in a couple other places, that there's more than one funding source, perhaps, for different elements. So states have to think through how they want to use the elements that they have or the supports they have to get there. Next slide. This is the part that I really want to get your attention on. It is very important, this process. using this tool, and I don't know of any state, with the possible exception of maybe Washington State, that has an 1115 waiver where they have managed to pretty much fund the whole ball of wax with one thing. Pretty much it requires collaboration, participation across departments. The various entities that really, in almost every state that I've worked in, have been, have helped, or the voc rehab people, the mental health side, sometimes the Department of Labor, sometimes education. There's this large cast of characters, and you would think that because people are all working, sort of pulling in the same direction, that they might at least know each other. But I want to tell you that filling out this tool, this is often the case certainly with our projects in the Aspire states, which we'll talk about a little bit in a minute. Sometimes it's the first time these people have ever met or been in the same room with each other. Particularly the gap or the chasm in some states between vocational rehabilitation and the behavioral health side is very great. It is very critical to get to know each other in order to get this done. One of the drawbacks is that, I'm sure none of you would ever have these feelings, but some people feel like it's only my division or my department that really cares about these people. These other people are just bureaucrats. They're just working their system. They don't care about the people. Only my system cares about the people. There's a whole lot of weirdness sometimes that comes to pass. And so getting to know each other in real life, working on this tool, has provided, I think, I don't know, Darius, others that are here that have been doing this work, I'm looking over there at Utah, can really testify to the fact that those relationships that you make working on this project, trying to figure out how to fund the employment service, leads to other collaboration down the way. So that's good. Okay, next slide. We can say this together as a mantra. When you've seen one state, you've seen one state. You all know this is true, but I don't know if you really know it's true unless you're a person that has only worked in one state. It is very hard to believe that you can't just, well, you hear that they're doing such great work in Illinois. I just went to this conference and I heard they have, how many is it, 55 IPS teams? They've got it all figured, I think more than any other state, right? You've got millions of them. So why can't I just take Illinois' funding plan and take it to Louisiana? Why can't do it that way? Why can't we do it that way in Denver? Well, you find out such things as the huge intricacies and variation in every single one of these things. The Medicaid eligibility, what you use as Medicaid eligibility, the service definitions of the service, who's the qualified provider, and this takes us to a lot of the conversations we've been having about peers and the importance of peers, the importance of having adequate reimbursement for peers, not having them be, second-class workers who don't, earn enough money when they can be, especially in the employment arena, a peer specialist is the living proof, of how work, equals recovery. So the reimbursement situations, the qualified providers, then you get to VR, where there are different payment methodologies. Some states use a milestone, some states use fee-for-service. The VR processes at the counselor level can create heartburn here and there. You may have a VR director who is extremely collaborative, cooperative, and does not believe that a person has to have been sober for 90 days before they can, work with them in VR. But you may have, several counselors buried out in some county who have been operating that way forever and are, determined that they're going to keep on operating that way. So that even at the highest levels, in all of our systems, we get enlightened and then we try to spread the enlightenment. It doesn't always get to every corner. So there's variation there. And another one that we're really finding with this new batch, I say Aspire, we have 7 states, right, Bob? There's 7 states that we're working with under a Department of Labor Office of Disability Employment Technical Assistance Project. And among those 7 states, we are seeing quite a bit of variation in the muscularity, I use that term, of counties. That is to say, is the county, how involved and how authoritative is the county work and the county presence? Earlier today, we heard somebody mentioning with respect to the 988, how the variations in counties, are going to make a difference in how that is enabled. Wisconsin is an example of one of the most strong county states there is that I've encountered. They are doing very well at implementing IPS, but what we have to do around the financing there is a very delicate dance, because their counties actually make Medicaid rules that may be different from one county to another, or process things a little different from another. Quite different than what we experience in a state that is a strong central state authority, or a strong central area where they make the rules. So the reason I'm harping on these variations is that hopefully you will want to, those of you that aren't, or even if you've got your toe in the water, get more involved with the learning community, or getting more involved in thinking about how you can finance not just IPS, but employment generally, which I divert for a moment from IPS to point out that many, many people need help with employment, but might not need the full meal deal of IPS. You're still going to have to figure out how to fund it. And so it's very important to recognize these things as you go through that grid. Next slide, please. So Medicaid is one of the primary movers here, and I'm realizing that I left off a couple states on there, but I wanted, we could spend, and people have, a whole day, 2 days, just talking about the funding aspects of IPS and the funding and how Medicaid can be participating in the funding. When I mentioned the process, I'll back myself up just for a minute. One of the things that was the most important, I think, in Minnesota back in the beginnings, when we did IPS back there at the beginning, was to find a Medicaid staff person in the state government there who we didn't know a thing, we didn't know what we were doing with Medicaid, had just tried to figure it out, and this individual was really, said, look, we're gonna be a partner here. You tell me in normal talk what it is that you think you wanna do, and I will try to translate it into Medicaidese. And once you learn that you really can't go to the Medicaid entity and say, oh, here, do this, do this. No, people really need to be we have to respect all these people in their various realms and accept their expertise, which is wonderful. But so there's a whole bunch of different Medicaid ways that people are attempting to fund portions or all of IPS. The first and the most common one that I know of is using the state plan that people have to cover specifically the medically necessary illness management services. And if you get that grid that I showed you a minute ago, when you go through that, you'll see that so much of what is the underpinning of supported employment is helping people manage the consequences of their illness, helping people with anxiety about going to the interview, helping people figure out how to organize their thinking, how to organize their time. These are the same medically necessary services that are provided when you're helping people get a house, when you're helping them get along with their brother, when you're helping them be in the community. It shouldn't matter the locus of the care. What you're providing is a medically necessary service to help people overcome the sequelae of whatever diagnostic condition they have that made them an eligible Medicaid person, because we all know that Medicaid is a medical program and we respect that. But we need to be really looking at the lens. What is it that's keeping this person from being successful? And supported employment, IPS, really targets the individual difficulties that the person has in a very person-centered way. So back to Medicaid. In Washington, they are doing it with a 1115 waiver under their Foundational Community Supports Program, along with supported housing. Kevin is very well aware of that work that TAC was so formative in helping with. Iowa is using a home and community-based method. The CCBHC that was mentioned earlier in Oklahoma, this is something that I know about CCBHC because I was involved in bringing that up in Missouri, but in Oklahoma, they have picked IPS as one of the evidence-based practices for they were in the wave of the CCBHC demonstration projects, so they're able to cover IPS under that demonstration, which is the only state that I know of that's doing that. There's other states, like Utah is using the 1915C, which is, I believe, B. Oh, you're a B? Oh, I got it wrong. And are you B3? B3, I transposed my numbers, okay. And Louisiana is just now beginning to be using a Medicaid waiver also to support it. So, but these are little shreds of places, and each one has their own circumstances around what they can do. I made notes to myself here. I got to make sure I say it all. The intricacies of Medicaid, you guys all know that there are many and varied, and it is hard work. We have to remember that it was only people that made those rules, and we're people, okay? So what I have always urged everybody that I work with on trying to make these financing, chipping away at it, is that nothing is immutable, and we have seen many things change. So I want to exhort you not to give up, even though it sometimes appears impossible. All right, next slide, please. I want to speak a moment about vocational rehabilitation. That agency covers many portions of IPS, and in some states, the relationship, I think I said this a minute ago, is very wonderful across divisions and departments. In other states, it is chilly would be the best way I could describe it. In my years of traipsing around, I have found that mental health department and division directors often have an erroneous idea about voc rehab. They think that the employment stuff should just be that voc rehab, that's what they're there for. That's what it says, vocational rehab. Why aren't they paying for all this? Well, there's various reasons. And my picture here, I love my pictures. Remember that even if they did every single thing you asked them to do at VR, their resources are the size of that orange compared to your need, which is the size of that watermelon. And that orange doesn't just cover behavioral health, it also covers people with orthopedic difficulties, people with DD, people with ID. So the resources compared to the need are small. So that's a thing to know. On the other hand, they have opportunities to do things for you that a Medicaid system alone is not going to be, like they can pay for tuition, they can pay for work boots. They can do things for people that your mental health system under Medicaid is not going to be able to do. And so the collaboration is absolutely, very important. It is also true, again, I mentioned that about the difficulties that we sometimes encounter with, I'd say it's the exception now rather than the rule, it's the exception, but there still are some areas where it's a barrier for people to have had substance use disorders, that are active, where people are unlikely to, or VR people are a little touchy. That's the exception rather than rule. I think it's gotten improved. The other thing about VR is that there's quite a lot of variation state to state in terms of the proportion of the people they serve with behavioral health conditions versus the other conditions. So some states have, I think Minnesota is an example of a state where the proportion of individuals with behavioral health has gotten larger. Some states it's still kind of on the small side. So that collaborative work that you do across departments and divisions, makes all the difference. Next slide. So other sources that are idiosyncratic that you have to kind of pay attention to in terms of your own state or how it looks, how you're going to do it, is again the business about the strong county authority, Wisconsin being extremely strong. Then the managed care involvement is quite varied. If managed care is in the picture, in Colorado, for example, the rates that they are paying for IPS are not the same depending on how the managed care person or people negotiate those rates. And I put Washington down there mainly because of as an example of how managed care entities are in the process in terms of the access. That varies how it works because you've got to work those boundaries too to get people into the service. Some states, some lucky states, still have general revenue supporting IPS startup as well as ongoing services. Minnesota is an example that has money that comes through their voc rehab agency that is actually state money, not federal money, and they are using that to support a lot of their IPS teams. Oklahoma is using a lot of state money still to support those teams that are not involved in the CCBHC demonstrations. And there has been grant funding in the past for infrastructure, the SAMHSA 7-state grant, where I got to meet some of you wonderful people who I'm looking at out here now. And those states, I just want to say, we have some really great successes from those states that began building the infrastructure once they got help to learn what is IPS, all the great work, you know, that Bob and Debbie and their team did to help people understand what the practice was. Then bit by bit, starting with a couple of teams and then expanding. The lack of complete coverage must be noted, as Kevin did before, in terms of really bringing things to scale, and Bob too. There's some states only maybe have 1 or 2 teams, and that's okay to start with, because you can't start everything at once. But having that goal to build along the way is important to really get the full infrastructure to get the benefits that we've described. And so our technical assistance grants now, we're just ending the first year of Aspire, and you can see the list down there. We had 7 states there that we have worked with. Next slide, and I think I'm just about ready to wrap up here. I want to reiterate how complicated it is to create the funding platform. It involves pain. It involves confusion. It involves, in my case, feeling like a dumbhead because I can't get it and I can't remember what the waiver this and that is, like I just did, got them transposed right here in front of you all. Anyway, the point being, if I can figure it out, anybody can figure it out, and it is worth it because employment is a key social determinant of health. Think for a moment of it as the linchpin. If you have employment, that means you have money, which means you can have housing, which means you can eat apples instead of McDonald's, which means you can live in a neighborhood where you don't get shot as readily. It means all of those things to us. It is the web, you know, that holds us together, and there's a lot. There's a very great study. It's a retrospective paper by Joe Maroney that looks at comparing about employed and not employed, and it demonstrates that for people who are not people who haven't had any behavioral health issues, unemployment leads to very bad outcomes. We all know people who have been unfortunately unemployed because factories close or whatever. We read about it all the time, how very bad it is for people's health when they want to work and they can't work. So we have an opportunity here. You guys are great. Thank you.
Thank you. Thank you very much. Fantastic. I just had one quick question. You talked about substance use disorders, and can you talk about how employment helps with recovery of substance use disorders?
That would be you. I have a couple of anecdotes.
Yeah, sure. Well, for many years, you know, everything about this has surprised me. I guess I just wasn't that smart starting out, but for many years we were surprised that in community mental health programs in general, about half of the people have co-occurring substance use disorder. They were just as interested in employment. They did just as well in employment, and they kept telling us that being employed helped them to control their substance use disorder. So then people started applying IPS in primary substance use clinics, and the big study on this was just completed in UK. They did a national study around the country, and this really illustrates the big difference between the US and the UK. So they did this study, they just finished about 6 months ago. They haven't even published the results, but they already went ahead and funded IPS in all substance use clinics in the UK. I mean, like overnight, the National Health Service is paying for it, right? How long does it take, you think, in the US, right? We have, on average, it's 20 years after we prove something is really effective before we start paying for it and trying to implement it. We have learned to modify IPS a bit for people who have substance use disorders. You know, for example, we all of our workers know that within your town or city, there are certain jobs where people are using marijuana or drinking all day long, and that's not a good setting for our clients to be in if they want to be in recovery We try to help make sure people are in a co-occurring disorders, treatment program, and that's part of the integrated care. We try to help people anticipate the first paycheck, because money is often a trigger for using drugs, and so we have them set that up ahead of time. Where's the check going to go, and make sure it pays for their apartment before they have disposable income, and so on. Is that enough?
Thank you so much for bringing your expertise. A fantastic presentation. Thank you. Thank you, Virginia and Bob. Thank you.